السلام عليكم ورحمة الله. نحن في تجمع الأطباء السودانيين في الولايات المتحدة سعيدين بنرحب بكم في محاضرة ثانية. Um, thank you so much for tuning in for our lecture. Today we'll have a lecture targeted on the knowledge of obstetrics and gynecology and pediatrics in the COVID-19. The title of the lecture is The Mother and the Child in the Time of COVID-19. I have a group of our one of our amazing group in FACOG to talk to you about this lecture. Please, if you are watching us, like and share this video, share it with your colleagues and whoever can from the knowledge that we will give in this lecture. I want to say Ramadan Kareem to everyone. I want to thank all the health providers here in the United States or back home in Sudan, especially doctors, nurses, pharmacists, all the healthcare workers who practice in Sudan in difficult times to save lives. I want to say thank you so much. I will start by introducing my guests for the lecture tonight in Sudan this evening here in the United States. I will start with Dr. Mohamed Abdelazim Akoud. He is an obstetrician and gynecologist. His residency in Hurley Medical Center, Michigan State University. He is currently doing a postdoc fellowship in maternal fetal medicine at Geisinger Commonwealth Health Center. Hi, Dr. Akoud. Don't forget to unmute yourself. Just you can say hi.
Hi, everybody. I do appreciate being with you tonight.
Thank you so much. My doctor is Dr. Mohamed Ibrahim. He is also an obstetrician and gynecologist. He is practicing at FirstHealth of the Carolinas at North Carolina. He did his residency at St. Joseph Regional Medical Center, Mount Sinai School of Medicine. He did his fellowship at the American College of Obstetrician and Gynecology. Hi, Dr. Mohamed.
Hi, everybody. Ramadan Kareem, and thank you, Saba, for this opportunity.
My next guest is Dr. Badreldin Abdelrahman. He's a pediatric neonatologist at Jersey City Medical Center, New Jersey. He did his residency in Newark, Beth Israel Medical Center and his fellowship at the University of Illinois at Chicago. Welcome, Dr. Badreldin.
Okay, thank you, Mohamed. Thank you for having me. Assalamu alaikum, Ramadan Kareem للسادة المشاهدين.
Last and not least, we have Dr. Salma Elfaki. We are happy to have her again in Saba Live. She is a general pediatrician at Nona Pediatric Center in Orlando, Florida. She did her residency at Orlando Health Arnold Palmer Children's Hospital, and she's an associate professor at the University of Florida. Welcome back, Dr. Salma.
Thank you, Dr. Mahmoud. Ramadan Kareem, everyone, and I'm happy to be back and be able to participate in this amazing panel. Thank you.
Thank you so much. So, as I mentioned, we will go to the presentation. We'll start from the mother at the time of, by the beginning of the delivery, by the pregnancy, and we will go through the steps with Dr. Akoud and Dr. Mohamed up to the delivery. And then we will continue to talk about how to take care of the neonates, and with Dr. Badreldin, and then Dr. Salma will tell us about the general pediatrics care. All of this in the time of COVID-19. I will start with Dr. Mohamed Akoud. I will put the slides in front of you, and you will start the presentation.
Thank you very much, Mahmoud. Today I'm going to present pregnancy and COVID with Dr. Mohamed Ibrahim. Our presentation is going to provide guidance regarding methods to appropriate screen and test pregnant women. And also we are going to discuss the reduction of the risk of maternal and neonatal COVID-19 disease by minimizing the hospital contact and appropriate isolation. COVID-19 disease is a global pandemic caused by SARS coronavirus 2. Currently, there's more than 100 million pregnant women worldwide. Approximately in Sudan, according to the birth record from last year, I expect or anticipate there's 1.2 to 1.5 pregnant women at the moment. Around 300,000 women in Khartoum state, all of them at risk for COVID-19. So what is the effect of pregnancy on COVID-19? Pregnancy does not increase the risk of infection. The infection is equal for pregnant women and non-pregnant women. It's just about the exposure. Do pregnant women tend to be more sicker? Yes, we do believe that, because pregnancy is somewhat immunosuppressed state, and women don't do very well with the respiratory infection in pregnancy. And particularly if they develop pneumonia and respiratory failure, they don't do well. They do become very, very sick. What is the effect of the COVID-19 on pregnancy? As any febrile sickness, it can increase the risk of miscarriage, preterm birth, preeclampsia, and cesarean delivery. Cesarean delivery, especially in women who had pneumonia, they have very high risk of cesarean delivery. On the babies, there's higher risk for stillbirth, and there's other risk for neonatal death and NICU admission, intensive care unit admission, but Dr. Badreldin will cover that. So far, we don't have any documentation for vertical transmission. Initially, there's very sick neonates, but after we get more information, we found out there's no vertical transmission, and most of this infection happen after delivery. So there's general guidance for outpatient obstetric practice during this pandemic. So so far there's no official or recommended treatment for this. So we hope for now is to work on the prevention. It is our first priority for now, and that can be achieved by social distancing, at least 6 feet, and very good hand hygiene. Okay. In OBGYN, we should postpone any elective or non-urgent prenatal visit or GYN visit at the moment. And we try to do most of the counseling and our advices through the phone and evaluation through the phone. And if we feel like this woman need to be evaluated in the hospital, we should guide them to come to the hospital. But all the women should be have a discussion or conversation over the phone before they come to the hospital. And we should decrease outpatient visit as much as we can. In average, pregnant woman comes to her healthcare provider or OBGYN about 11 times during pregnancy. And during this COVID-19, we would like to decrease this number as much as we can. Routinely, we bring the woman to the office as soon as she finds out she's pregnant, and usually that about 6 to 8 weeks or so. But at the moment, we don't do that to bring the woman to the hospital. Instead, we do a phone call and try to do telephone OB intake. And that can cover all the medical history. And if needed, some women need to come to the hospital. We bring them just for further evaluation, like very sick patient with pre-existing uncontrolled diabetes or history of cardiomyopathy or so. Some women, they need early evaluation to bring them, but for routine OB intake, we don't bring them early in the pregnancy. Around 11 to 13 weeks, that's a very critical period in pregnancy. We bring them for dating ultrasound. On the same time, we do genetic screening for chromosomal abnormalities and congenital malformation. And I do believe if this available in Sudan, they do this testing and screening. That's a good time to have the first prenatal visit. But if there is no availability to do the nuchal translucency and screening, we can skip that appointment too. And instead of that, we can have for interview. Around 20 weeks, usually we bring them for anatomy scan, and that's very, very important. And all women should come to this visit for anatomy scan to detect all the major congenital malformation. In addition to that, they can do like initial physical examination with the provider. Around 28 weeks, we do another visit, which is very important, to screen for gestational diabetes, also to do some vaccination like the flu vaccine and whooping cough vaccine. Also, we can order some blood work like TBC and syphilis test. Around 32 weeks, we do bring them if we feel like they need fetal surveillance, if they have pre-existing condition like chronic hypertension or diabetes, or the baby diagnosed with fetal growth restriction or so. At that time, we do fetal surveillance, and usually and typically we do that by non-stress test twice weekly. However, at this pandemic period, we do perform biophysical profile weekly, and that's sufficient and equal to maybe NST twice weekly. After that, we just, if the patient does not need the fetal surveillance, we just do fetal kick count, and we ask the mother to count 10 counts in 1 to 2 hours when the baby is most active, and that's enough. And for postpartum period, usually a phone call is enough, especially if the patient had a vaginal delivery and did not have a C-section and she doesn't need a wound evaluation or so. So in summary, all women should come at 20 weeks, 28 weeks, and as needed if we need them to come more often, as needed. But all women should have maybe 2 visits, and that's all for now. Otherwise, all the counseling and discussion should be over the phone. So if the patient needs to come for her anatomy scan or 28 weeks or any other ultrasound evaluation or so, they should have a phone call and discuss with the provider 2 things initially. They do discuss like if there's any symptoms of COVID-19 that include fever, cough, shortness of breath, or chest pain. And if there's no symptoms, that's okay, so the patient can come to the hospital. If there's symptoms can be mild, which is cough without fever, or moderate cough with fever. These women do not need to come to the hospital and should be directed to the testing center, and they shouldn't come to the hospital and be evaluated in the testing center. If the patient has severe symptoms, which is a fever, cough, plus chest pain and shortness of breath, these women should have to come to the hospital for evaluation. If the patient is asymptomatic, but she had a history of contact with a positive screen person, this woman should stay at home in self-quarantine. And that's all about the outpatient visit. So for outpatient visit, we should screen them and see what's going on. So this screening is almost the same for inpatient and outpatient, and phone calls to labor and delivery I will just cover in a minute and should be triaged. Symptomatic patient should be managed as they have COVID-19 positive until we prove otherwise. And always we should wear mask N95. And all women who have like high suspicious or positive result should be should stay in a designated area with only COVID-19 patient. So from all what I said right now, I do believe like we have to have very good coordination with the phone companies, Zain, MTN, and Sudani to provide hotlines. And as I said, there's 1.2 to 1.5 million women who are pregnant right now, and they should get this counseling over the phone. And I do believe like the company should cooperate with the Ministry of Health to provide this service to our people in Sudan. So the previous figure was about outpatient visits. However, if this patient need to come to labor and delivery for obstetric complaints, these complaints can be very serious. That include symptoms of preeclampsia, vaginal bleeding, decreased fetal movement, or so. This very concerning, and this woman should come to the hospital. But which hospital she should go? So if the patient complains of this, we should screen again if the patient has mild, moderate, or severe symptoms, or no symptoms at all. If no symptoms at all, this woman should go to the closest hospital to her area and be evaluated over there. However, if this patient had any symptom, she should go to the designated hospital managing COVID-19. So if the OB concern is not that significant and patient needs to stay at home, also we should evaluate about the COVID-19 symptoms. And if there's mild or moderate symptom, she should get tested, maybe plus or minus chest X-ray. If there's severe symptoms, patient needs to be evaluated in the hospital who are managing pregnant women with COVID-19. If there's no symptoms and there's no significant concern OB-wise, this woman should ask about the contact. If there's contact, patient should be self-quarantine and maybe in 2 or 3 days contact again by a phone to see what's going on with her. So the appropriate isolation and sanitation. So all health care providers should follow the CDC, Center for Disease Control and Prevention, personal protective equipment recommendation until COVID-19 has been rolled out. That recommendation includes surgical mask, protective eyewear, gown, and gloves. N95 mask should only use if there is high suspicion or the patient tested positive for COVID-19. Aerosolization should be avoided because it does not help that much with the fetal resuscitation. If the indication was non-reassuring heart tone or repetitive deceleration, the oxygen does not help that much. On the same time, it will increase the risk of infection because the patient at that time, she does not cover her mouth and nose with the mask. So we try to take the mask out and put the oxygen. That will increase the risk of infection and should be avoided. And if used, we should use the nasal cannula. Second stage of labor is it has the highest risk for aerolization, and N95 should be used all the time. Always do practice hand hygiene. Always, always. So, so if the patient is coming for cesarean delivery, like a scheduled cesarean delivery or a scheduled induction of labor, we should call them the day before and screen them for symptoms and signs of COVID-19. If they are free of symptoms and signs, they are okay to come to the hospital. But if there has any symptoms, they should be evaluated before coming to the hospital. And the admission can be delayed for 2 to 3 days until we get the result back. So usually the severity of the disease peak in the second week. So if we have like any patient tested positive, we should try to deliver her before the second week just to optimize the delivery and get like a control setting for delivery. And from now, Dr. Mohamed Ibrahim will continue this presentation. Thank you.
Thank you, Mohamed and Saba. As Dr. Mohamed was saying, there should be some consideration for the outpatient care of pregnant patient in the office, and also there is also important and special consideration while taking care of COVID-19 patient during the hospital stay. So for the general changes in the labor and delivery, we should adapt and adjust what we have from resources, measures, and involvement of all people who should be taking care of the patient, so we can have a better environment. So we should have a better outcome for those patients. So on admission, patient should be aware of, and her family that should also be aware of that. Visitation are very limited. Somebody who's coming, if patient is coming for induction of labor, or if she's admitted for elective cesarean section, or she came to labor and delivery triage for any obstetrical problem, from home, she should limit people who should accompany her. So we can minimize the exposure of the health personnel to people. This would minimize the chance of the spread of infection. So when somebody coming with somebody to the hospital, she should choose at least one person to accompany her to the hospital. Also, admitted women to labor and delivery should be informed that she should be restricted to the place where she's admitted to. She should be staying in the room most of the time and all of the time. This also applies to people who are supporting the patient or the person who chooses to be accompanying the patient in the room. So they should be staying in the room. This for patient who's sick and who's not sick. Also, to minimize visit to the hospital, elective procedures, for example, cesarean section. Before patient come to the hospital, she should do her pre-op labs, for example, CBC type screen, and all the preparation for the cesarean section as outpatient. She goes to the lab before coming to the hospital. Also, this minimizes the time being in the hospital. So the respiratory precautions and personal protective equipment, we use it in certain situations with specific patient status, and we choose from them the suitable options. So for patient in the hospital setting, patient and the physicians and all the staff should wear surgical masks. This is applied mostly for patients who are asymptomatic or patient who has mild symptoms. So physicians and other staff should be having face mask, surgical mask, and the patient also has surgical mask. This will also minimize the risk of spread. If the provider is taking care of a patient who has upper respiratory symptoms, and in this case mild symptoms, he should be also wearing the personal protective equipment and wishing both the gown, the gloves, and the surgical mask and the face shield. And the patient also has to be wearing a surgical mask. Caring of a patient with suspected COVID-19 or established positive COVID-19, and also patient who possesses a risk of aerosolization, especially during second phase of labor when patients are pushing. Physician and staffing should wear personal protective equipment, gowns, gloves, surgical mask, and on top of that, they should use N95. And the patient, while she's doing that, or while she's subject to the procedure or the management of labor, also should have surgical mask on. Next. So for preterm labor management, that's one of the condition, obstetrical condition. Patient come to the hospital for inpatient care. Most of the time, patient will stay at least for 8 hours if they are really proved to be in preterm labor. So in taking care of patient with preterm labor, special precautions has to be made for the usage of steroids and the NSAID. The common NSAID we usually use in the management of preterm labor, which is indomethacin or Inducin as a tocolysis. For the steroids, as Mohamed was saying, that pregnancy in general positions women in some sort of low immune system or immunosuppressed. Using the steroid on top of that, that also will make the pregnant ladies more susceptible to infection. So there should be special considerations when we should use the steroids and when we should avoid it. Always remember for the tocolysis or tocolysis, when you use it, nifedipine is your safe drug, which is a brocardia, which is a calcium channel blocker. Is benign. It has low side effect and toxicity profile. So in taking care of patient with preterm labor, patient status and gestational age and the choice of the medication, all has to be worked together to provide safe care for the mother and appropriate management of labor and delivery. For example, patient less than 32 weeks, which is put the baby is in high risk of prematurity and premature complications, especially respiratory distress syndrome and other prematurity complications. Those kind of gestational age we have really to pay attention to. We can start by using the steroids, which is usually betamethasone or dexamethasone. For mild cases, no problem to use them as far as the gestation is less than 32 weeks. Indomethacin or Inducin can be used or may be considered, and the magnesium sulfate may be used. So on mild cases to moderate cases, less than 32 weeks. If the patient is less than 32 weeks and has severe disease or severe COVID disease, then using the steroids and magnesium sulfate has to be after discussion with all people who are taking care of the patient. That's including the maternal fetal medicine specialists, the pulmonary care and critical care specialists, obstetrical anesthesiologists, and the neonatologists. So all people has to come to decide about the usage of the steroids and the magnesium sulfate. As I said, using nifedipine is benign, has less side effect and toxicity. It can be used when the patient is less than 32 weeks and has severe disease. Patients who are between 32 weeks and 42 weeks, those are in better shape than early gestation because the baby will have less risk of prematurity and the chance to have more complication in relation to the baby is going to be less in severity. So those patients, you need to take it a little bit easier on them when you choose the medication. For example, if the patient has mild disease or moderate disease, COVID-19, and she's been the age between 32 weeks and 24 weeks, the use of steroid has to be considered. Okay, because we're looking now on a baby, he is in better shape in maturity. Now, putting the mother on high doses of IM steroids for 2 days, that can put the risk of the infection to get worse for the mother. For mild, she might go into severe symptoms. So we have to weigh the risk and benefit in this area. So nifedipine, as I said, can be used safely without problem in those patients. If the patient is really sick, severe disease, okay, stay away from the steroids. For patients who are between 32 weeks and 34 weeks, stay away from the steroid. stay away from the NSAIDs and stay away from magnesium sulfate, unless really needed. Okay, but I will go with nifedipine. Okay, there is no indication for steroid and there is no indication for tocopherol for any patient between 34 weeks and 40 weeks and above. There is certain area where we apply the use of steroids between 34 weeks and 36 and 6 if we think that the patient may have imminent delivery. So for mild cases, we can consider giving the steroids. For severe cases, avoid giving the steroids for those patients. No tocolysis past 34 weeks. Next. Induction of labor. Induction of labor for any medical or obstetrical indications in asymptomatic patient should not be postponed, because as we know that the first week of the disease is most of the time is benign. There is no severity and there is no critical issue about the patient status. But after 2 weeks, the patient can get sick. So if you have a patient who's 39 weeks pregnant, she had favorable cervix or induction, and she's just diagnosed with COVID-19 and she's asymptomatic, I will schedule her for induction, because after 1 week, when she's going to be 40 weeks, she might be sick and she may have complications, we may have died. Also, the management of the first stage and second stage of labor should be the same, no difference between patient who is COVID-19 positive or not. For the fetal resuscitation or intrauterine resuscitation for any indication, maternal or fetal, and mostly reflected by abnormal fetal heart racing, meconium, and fetal distress, as we mentioned, or Mohamed mentioned before, that utilization of oxygen should be very cautious or should be very careful. Also, the measure for blood transfusion has to be strong. That will start before the patient goes to the hospital. Earlier, during prenatal care, make sure that your patient, during the pandemic, her hemoglobin is really good by supplying them with iron, folic acid, vitamin B12 if they need it. And if you need to give IV iron infusion to correct the anemia as outpatient setting, that will be great. So the patient, when she goes to the hospital, she should have at least very good hemoglobin, because as we know, labor itself can cause blood loss. Postpartum period itself can cause blood loss. If having that patient start to have some sort of complication, postpartum hemorrhage, DIC, then if she came to the hospital with low hemoglobin, that will put her in a risk of very severe morbidities and will put her in a risk of mortality itself. So if we decide to give blood for somebody who is really not sick, when I say not sick, not DIC patient, not very critically sick COVID-19 patient, and there is no strong indication for urgent massive blood transfusion, most of the time in the situation like correcting severe anemia after delivery, somebody will deliver, her hemoglobin is 6, patient is asymptomatic. Okay, you can start with giving the patient 1 unit of blood and then evaluate the hemoglobin and the patient clinical status. If the patient is walking, tolerating walking, post-over day 1 or postpartum day 1, following vaginal delivery or cesarean section, and hemoglobin is 7, there is no tachycardia, there is no feeling of dizziness, I will give her iron. I can give her an infusion while in the hospital, or I can give her iron supplement to go home with. COVID-19 severity peaks, as we mentioned in the second week. It may be prudent to expedite delivery, if possible, for a term patient, and also for patients who are positive with mild symptoms or asymptomatic patient. COVID-19 is not an indication for cesarean section. So if you have somebody who's really came to live and deliver, and she's like 39 weeks, and she has symptom, fever, shortness of breath, fatigability, or she has some sort of respiratory difficulties, and she's 39 weeks, that's not reason to take her to operating room. So COVID-19 is not indication for cesarean section by itself. So in preparation for cesarean section, we can start with multiple things. You have to set up your operating room. If possible, you can dedicate one operating room for COVID-19 patient. And I would assume this in a big centers, and for small centers, and even for developing countries, most people they will share the same room. Especially in Sudan, you can get the room ready where you can handle COVID patient with the idea of isolating those patients when you want to do the C-section from the other needs from the operating room. Just let's make it like that. In other hospitals, like bigger hospitals or tertiary centers, they may have a specific or separated room as OP room for cesarean section. I'm talking about big cities like Khartoum and other places where they have big hospitals. Most of the time they have separate obstetrical unit equipped with an OR. So when you set up the room, make sure that you have all the personal equipment ready for use and your supply is 100% to handle your cesarean section, emergency or elective, and 95 available, and stack them under protection outside of the OR room, so and make them available where the patient can, or the staff and the physician can use them and put them on before go into doing the procedure. Also, there should be some sort of drills, simulation training, so we can build the skills and knowledge of the staff and health personnel to equip them with all the knowledge and the skill to handle the situation where they might need to go into the operating room for emergency, in case of urgent or emergency cesarean section. Sometimes we call a C-section within minutes, within 10 minutes. So in those cases, we don't need to rush to the OR and forget about all the protective measures and get the disease from somebody on the way. So everybody should at least be equipped and ready to handle those situations on a timely measure. For pain control following cesarean section or even postpartum, the use of NSAID is allowed as far there's no severe disease, just to minimize the dependency for opioids. But again, we usually following cesarean section, we in routine use without COVID-19 issues, we put patient pain in scales. For example, from 1 to 2, we give them just Tylenol. From 3 to 4, we give them NSAID. And from 4 to 5 or 6, we give them very low dose of opioids like Percocet, 1 pills. And when they are like 5 to 6, we give them a little bit twice the pills for opioids. For example, 2 tabs of Percocet instead of 1. When the pain is 7 to 10 or 8 to 10, then you can consider doing IV or IM narcotics. And the risk is always wide. You can choose your best pain medication to control the pain. The infant following the delivery, either cesarean section or vaginal delivery, should be immediately separated from the mother. Caring of the critically ill COVID-19 pregnant patient in all situations. If the patient gets admitted because of the COVID-19, because of pneumonia or adult respiratory distress syndrome, she had further complications of the COVID-19, or the patient admitted for obstetrical indication, she came with preterm labor, or she came in labor, or she came with abrupt placenta, or she came with cesarean section complications during pregnancy. So those patients has to be treated really with this multidisciplinary group involving the maternal fetal medicine doctors, infectious disease, and pulmonary and critical care, and OB anesthesia, and neonatologists. Okay, that will bring people together and giving and providing the best care for the patient. Also, as we mentioned, be careful about the use of steroids for the fetal lung maturity, guided by the gestational age, avoidance of the NSAID during severe disease, and the magnesium sulfate because of the toxicity. Also, attention should be made for IV fluids. IV fluid should be restricted. You can go with less than or 75 ml per hour for critically sick patient. And also during the hospital stay for any obstetrical indication, we don't need to, or we shouldn't forget the baby. This is another person inside or in-house. We have to take care of the patient the same way we take care of the mother, or the baby the same way we take the mother. So we have to make sure that the baby has very good well-being. This usually we assess starting from the kick count at home, starting from kick count in the hospital. For other places, we have the ability to make sure the baby is in a good well-being status by doing non-stress test, ultrasound for biophysical profile, measuring the amniotic fluid index, and also the fetal growth. Make sure the baby doesn't have IgR. Most of the time are related to COVID or could be related to COVID, which is very rare. Patient while in the hospital, if we took care of them and they are good, for example, when patient delivered, she should go home. Patient had a cesarean section or patient treated for preterm labor. Minimizing the hospital stay is a very important thing we have to look at. Those patients has to be discharged as soon as they are good to go. For example, in routine practice, we discharge patient on postpartum day 1 following vaginal delivery. But in pandemic and in this situation, if the patient is okay to go home, I think we can discharge patient past 12 hours. They don't need to stay overnight if they are doing fine. There is no postpartum complication. When they were admitted, they never had any medical complication like diabetes or hypertension, preeclampsia, eclampsia. So those can go home in less than 24 hours. Also for cesarean section, we discharge patient routine cases on post-operative day number 2. And we can discharge those patients earlier than that on post-operative day number 1 or postpartum day number 1 if they retain their bowel functions and their bladder functions and they're tolerating that, tolerating mobility, and they don't have any complications outside of the any complication because of the delivery, cesarean section or vaginal delivery, and they are good to go. They can go home after 1 day and maybe less. So when we discharge patient, okay, we have to talk, especially patients who are sick with COVID-19. We have to involve the pediatrician and the neonatologist on the discharge process so they can time the discharge of the baby too, because you can't send the baby and the mother is still in the hospital. Okay, the baby has to be staying where the mother is. Also the same for the mother. Discharge should be timed, if possible, with the discharge of the baby. When we send patient home, it will be generous from the hospital. This is everywhere. To give the mother some sort of supply to go home, this can include baby supply, diapers, for example, bottles, if they are gonna bottle feed. Also, some disinfectants and hand sanitizers, because she's gonna go to the community. Some people, they may come and visiting her, and we know in Sudan, people love to visit people when they are postpartum in group, we should avoid at all. Anyhow, they can go home with those supplies. If she had severe preeclampsia or hypertension, chronic hypertension or gestational hypertension, it will be good to have an access to a blood pressure check machine. It would be great if the hospital can provide that. If not, people, family members, friends, so she can go home so they can monitor her blood pressure. So when they go home, very important, stay home should be applied. This involving the patient, so she shouldn't go outside, do shopping, and also involving the visitors. You know, when she came home, if she's not sick or she doesn't have COVID-19, people to try to stay away from visitation, restrict visitation very tightly. Also, those patients, they should be provided by materials, like study materials about the disease, and so they can educate themselves more and educate people in the community more. All postpartum visit can be managed and handled through telemedicine. And this can include questionnaire about the patient status, how she's doing, if she has any problem, does she feel anything abnormal, fever, discharge, pain. You can visit every aspect of the postpartum problems on the phone or using the telehealth. Also, you can provide contraceptive counseling on the phone. You can go through all of the options available for the patient. And also, you can send prescription to those patients. You can also do postpartum depression screening using specific questionnaires. And you can send prescription. And also you can screen for domestic violence and provide education to the patient. I think postpartum check or postpartum visit can be handled by telehealth or by phone all around the world, not specifically in modern countries. For example, in Sudan, people can use a WhatsApp to chat with the patient, or they can use their own phone, or they can do FaceTime to discuss all those things with the patient remotely. I think that covers the intrapartum and postpartum, the hospital care. Thank you very much.
Thank you, Dr. Mohamed. I will discuss in this presentation, I will discuss the perinatal transmission and congenital infection, and also we're going to go over the neonatal management recommendation. The slides, Mahmoud. Respiratory secretion and the saliva are the primary infectious fluid for human-to-human transmission of the COVID-19. The possibility of maternal to fetal vertical transmission is a major concern among the neonatologists and perinatal specialists. Until now, there is no direct evidence that the vertical transmission exists. For managing antenatal, intrapartum, and neonatal care, we would like to understand whether the virus can be transmitted via the placenta, or which maternal fluid may be infectious, and what are the maternal or the neonatal risk factors which can increase the perinatal transmission. This is a study from Wuhan, China, and it's published in March 26, 20, and it is about, in this study, 33 neonates born to mothers with COVID-19. They were recruited in this study. Three babies of those 33 neonates, they were found to be positive for COVID-19. The mothers were positive. They have positive tests just between the day of delivery and 3 days prior to the delivery. The three babies were identified. Two of them were 10 babies, 40 weeker, and one was a premature baby born at 31 weeks. All three babies were delivered via cesarean section, and one baby has the rupture of membrane prior to delivery, and all babies were separated immediately after birth. The 210 baby presented with fever and temperature instability just 1 or 2 days after the delivery. They have an X-ray done, and they were diagnosed with pneumonia and recovered. The premature baby was sick from birth, and the sickness was related to prematurity, RDS, and also he has positive blood culture. So the three babies were tested positive with nasopharyngeal and anal swab at day 2 of life and 4, but all of them, they were negative by day 6. So the author concluded that there is the vertical transmission cannot be ruled out from the study, and they recommend that to screen pregnant women and implement strict infection control measure and close monitoring for the neonate. This is also another study from Wuhan, China. From China also, it is about 6 babies born to mother with COVID-19. All these babies were tested, and the virus was not detected from their serum, and also was not detected from the throat or nasopharyngeal swab. However, they tested the antibodies in their serum, and the IgG was found elevated in all of the babies' serum. And we know that the IgG can cross the placenta, so this is most likely is coming from the mother. But IgM was detected in the serum of 2 infants, and we know that the IgM does not cross the placenta. So that means IgM might have been produced by the infant because the virus crossed the placenta. So these publications or result led Dr. Kimberlin, he's an infectious disease specialist from University of Alabama, to publish this article. And in his article, he is questions. He asked, like, do we really believe that the SARS infection can acquire in utero based on this publication? And he stated the fact that most congenital infections are not diagnosed based on the IgM, because the IgM also they're prone to false positive result and false negative result. And the second thing also, the sensitivity of the and specificity of the IgM is less reliable compared to other molecular testing. And those babies, all the babies were tested negative for the virus. So he concluded that more definitive evidence is needed in order to prove there is a vertical transmission. So in the next 2 slides, I'm gonna just all this summarized several studies and case report for evaluation of positive mothers with COVID, and also evaluation of their neonates. So most of all those babies were born with a C-section and immediately separated after the birth. And they tested the amniotic fluid and the cord blood. They tested also the neonatal nasopharyngeal swab and the breast milk. And the virus was not detected in all this fluid from all these samples. And this is a good thing. Next. So based on this evidence, SARS has not been detected in the cord blood, amniotic fluid, or placenta. And the maternal viremia rate appeared to be low, so suggesting that the vertical transmission are unlikely. And the positive IgM results are not a definitive evidence of in utero infection. In many of cases, early infant infection might have been due to postnatal contact with infected parents or caregivers. So neonate born to a woman with both symptomatic COVID-19 positive as well also or symptomatic mother but pending result should be considered a person under investigation or POI. And for the healthcare worker or the pediatrician or neonatologist attending the delivery, they should use gown and gloves and wear also N95, respiratory mask, and also goggles to protect their eyes. And this protection is very important because the maternal virus aerosols, and also if in case we need to perform newborn resuscitation like a CPAP or PBV, giving positive intubation, all this increase the risk of infection. But being just a mother is COVID positive is not an indication for a pediatrician neonatologist to attend delivery unless there is any other indications. After birth, infant must be separated immediately to decrease the risk of postnatal infant infection from the maternal respiratory secretions. An infant who born at term or near term or appear well, they should be admitted into a specific area, separate from the newborn unaffected by the maternal disease. And also the newborn should be bathed or given baths immediately after birth as soon as possible, and in order to remove virus on their skin. The clinical staff the clinical staff who care for those babies, they use droplet and contact precautions until the virus testing result is negative. Yeah. So infant who born and require neonatal intensive care unit ideally should be admitted to a single patient room with the potential for negative room pressure or HEPA filtration if available. And if this is not available, those babies, they should be separated from other similar infant with same condition at least by 2 meters or placed in the isolate. Okay, and the staff caring for them, they should wear also PPE. They should airborne, droplet, contact precaution, and the negative room pressure should be used, if as I said, if it's available for any babies requiring CPAP or any form of mechanical ventilation. So if the mother chooses to room in with her infant, rather than to be separated, or if the center does not have the capability of separating all this infant in a specific area, then the infant should remain at least 6 feet or 2 meters from the mother. And she also, they use a physical barrier like a curtain between the mother and infant. Or if it is possible, also the baby can be placed in isolate, also 2 meters away from the mother. So molecular testing should be done first at 24 hours of age, and the repeat test also should be repeated at 48 hours of age for well newborn, this who discharged before that, it is not mandatory. Okay, for the infant who tested positive on initial testing, we need to repeat the test 48 to 72 hours until we have 2 consecutive negative tests. All babies who test positive with the disease, they should have evaluation, should be evaluated with CBC, CRP, and PMP, LFT, and also coagulation profile and chest X-ray. For the infant who cannot be tested, ideally should be observed for 14 days. And for those who tested negative, they can be discharged home to the other designated health caregiver who's healthy, does not have any symptoms. So till today, we don't have any study demonstrated the presence of the virus in the breast milk. And we know that the breast milk contain antibodies, and these antibodies could be protective for the babies. That's why for the babies. That's why it is really recommended. We recommend all the women to pump and to provide breastfeeding for their babies. And the risk of transmission is usually from the droplet transmission if the baby is in close contact with the infected mother. But mothers, they might use appropriate hygiene. Okay, they clean their hands, clean also skin over the breast and also the material, and they can pump and they can provide this milk to other healthy caregiver who can feed the baby. For the woman who decided not to breastfeed, so babies can be given formula, and also he should be fed by other healthy caregiver. So when symptomatic mother should care for the baby, when they are afebrile for 72 hours and without use of any antibiotic, and at least 7 days have passed since the first symptom started. And this is according to CDC. If it is possible, they should have 2 consecutive negative tests. This is a case report for a 3 weeks old infant. He born at 36 week. He went home, discharged from the hospital after 2 days in the hospital, and he has a contact with a sick family member. He came at 3 weeks of age with 2 days history of URI. He has a nasal congestion, and he was tachypnic, and he has poor feeding. On admission to the ER, he found to be in hypoxic. His oxygen saturation was in the lower 80s. He had an X-ray done, and in the X-ray showed that the first one showed that he has possible consolidation and right upper lobe collapse also. And the baby was like transferred to other hospital, pediatric hospital. During the transport, the baby developed, he was hypotension and he was tachycardic. And when he got there, the baby was intubated and he was received IV fluid and vasopressor. The second X-ray showed that still the baby has some right upper lobe collapse and some infiltration on the other side. And because of the history of sick contact, baby was admitted to the intensive care, and he had COVID-19 PCR from the throat scent, and he was started on antibiotic, and also he was started on azithromycin and hydroxychloroquine. And second day from admission, the baby was developed a pneumothorax. Okay, you can see from this X-ray. Later, the baby improved. At day 7, the result came back, and he was positive for COVID-19. But baby continued to improve, and at day 9 of life, baby were able to be discharged home with oxygen. And this is tell us how serious this disease can be, and we need to take all the precautions measures in order to protect those babies. Okay. Thank you.
Thank you so much, Dr. Badreldin. Before we go to Dr. Salma, I want to remind everybody that we will answer your questions at the end of the lecture. You can ask your question in the comments, and then we will go back to it and answer it after Dr. Salma's presentation. I want to also remind everyone who is watching us to donate for SABA, especially for our Hamlet Eid ala Eid. This way we will be able to support our support all SABA activities, specifically supporting our community in Sudan this COVID times. يعني اي زول لو بيقدر يتبرع باي حاجه، اللينك موجود في البوست اللي انا خدته في الفيسبوك، وممكن في اللينك العام بتاع التبرع لسابا. دكتور سلمى حتكلمنا عن Dr. Salma will tell us about how to take care of the general pediatrics population and to arrange the pediatrics visits, and she will have very interesting presentation. I will put the presentation in front of you, and Dr. Salma will start.
Okay, thank you, Mahmoud. So what I will be talking about today is care of the pediatric patient during the COVID-19 pandemic. So I'll wait for you to put up the slides. Okay, and care for the pediatric patient involves your acute care and your routine health maintenance. Health maintenance, this is defined as the routine care that follows a child during their development and providing necessary preventive care to allow the child to grow up to be a healthy adult. The American Academy of Pediatrics strongly encourages continued provisions of healthcare for children unless community circumstances due to the pandemic require adjustments. So this is, we're talking about vaccines, we're talking about your routine well visits, when the children go in to get weighed and measured, you discuss concerns about their development, any screenings that part of the routine pediatric care can be done. And if the child needs any referral to a pediatric specialist or subspecialist, that should continue to be maintained. Unless, of course, there's a complete shutdown, and there's alternatives and some things that we will talk about later that can be done to try to continue care for your pediatric patients. One role for the pediatrician during these routine visits is to reinforce public health measures to your patients. Public health measures include social distancing, 6 feet or 2 meters away from each other, frequent hand hygiene, and use of barrier methods, whether it be masks for ages 2 years and older, to try to prevent the spread of droplets. As far as well child care, these should occur in person when possible. Comprehensive history, developmental screening, physical exam are necessary. Newborn visits fall under that as well. And as my previous colleagues, Dr. Badreldin mentioned, newborns, especially even in that first month of life, are very vulnerable and highly susceptible to infectious diseases. There are other issues that can occur with their feeding, jaundice, and other conditions that can occur during this period, and so they need to be monitored frequently, and those visits should be prioritized. As far as the routine well visits and vaccines, those should be prioritized for patients under 2 years old or 24 months, as that's where you have your primary series of the vaccines against all those diseases that we have managed to be preventing at this time. If it's not possible to conduct in-person visits, telemedicine can be utilized for routine care. Via telemedicine, whether it's a video or audio, that can be utilized to complete the comprehensive history, complete developmental screening, and provide any anticipatory guidance related to the particular age and the current circumstances that your area will be going through. If that is the route that can be conducted, some new practices or new practice has been implemented here, and I'm personally actually doing this in my office, where we complete the telemedicine aspect of the visit, and then have the patients come in through a drive-through where we check their vitals, address any particular issues, perhaps a limited physical exam, and try to administer vaccines in their vehicles. And this allows for a safe and efficient way to provide vaccines and prevent any other diseases from spreading. A comprehensive physical exam can be done at a later date, obviously, and you should use your clinical judgment based on what the patient is, the patient's history is. I'll touch a little bit about breastfeeding. My colleague, Dr. Badreldin, had mentioned it. When it comes to breastfeeding, ideally, we need to, the families with confirmed COVID-19 or any person under investigation should avoid being around the child, as with any other illness, and in particular, maintaining that 2-meter distance or 6 feet, and using protective equipment, masks and such. As far as the mother and the baby, if either one has COVID-19, it is recommended for moms to continue to breastfeed. This is because of the antibodies and the protective properties of breast milk. However, that should be done in a safe manner. So it's suggested or it's advised for moms to pump or express their breast milk and have a healthy alternative caregiver provide the feedings for the child. This is, of course, after mom performs appropriate hygiene, so washing her hands, cleaning the breast area, wearing a mask while she's pumping. However, there are some moms who want to nurse directly. This is discouraged, but of course, that's up to the mother. But provide appropriate education as to the safest way to do this, and that is hygiene, cleaning, and using the protective covering while nursing the child, and just being extra careful. As far as moms who choose not to breastfeed and would rather go with the formula route, that is fine. Obviously, as I mentioned already, it is preferred or encouraged to provide breast milk if possible, due to the protective qualities. But if they choose to formula feed, then the healthy caregiver should provide the feedings to the infant. Telemedicine can play an important role here, as you can provide clinical support and counseling to moms who are breastfeeding or who may have difficulty with breastfeeding. Patients with chronic illnesses are our special population. These are kids who are higher risk due to underlying chronic conditions that could be present from birth or acquired later on in life. Common chronic illnesses, asthma, diabetes, immunosuppressed patients due to autoimmune issues or cancers, any congenital issues that may occur. So these patients that are higher risk of becoming ill due to their underlying chronic illness, but also with COVID-19. It's important to continue with routine care with these children and provide the vaccines that they require, that are necessary. You should be able to prioritize these visits and plan for them to get sick and plan for what you want to do in your practice or in your clinical setting to care for these sick patients. It is suggested that you can prepare a list of resources that you could provide to these families, phone calls, areas they can go to, pharmacies, any organizations that could provide support to those particular children with their specific condition. Make sure to establish a communication plan with the family. This could be email, it could be social media, WhatsApp, or direct access to a phone number that they can call and discuss any concerns that they have with you as their pediatrician. Make sure to provide necessary prescriptions and refills in cases of complete lockdown, that they have enough at home to make sure that they manage their condition and not become sick due to their underlying condition. As far as acute care, it is recommended to try to keep kids out of emergency rooms and hospitals at this time. Children are prone to getting all sorts of infectious diseases just by the nature of their curiosity with the world and touching everything and putting things in their mouth and not doing very well with maintaining hygiene, which is hand washing and staying away from people and whatnot. So if it's imperative that you continue to provide care in a safe manner. Advisably acquire some PPE or personal protective equipment, and if in limited supply, learn how to reuse it if necessary. There are multiple studies available now that show how you can reuse your PPE appropriately. In case of a clinic or healthcare facility that cares for children, develop a plan or strategy to provide care safely in your facility, considering the following. How are you going to social distance your patients within your building? What are you going to do with the waiting room? Are you going to space people in the waiting room? Are you going to have them wait in the car until you can call them back and into the exam room? So these are all different strategies that, depending on where you're located and what your practice can do, you can think about. Decide how your office workflow will be, and decide how you're going to maintain the cleanliness of the premises. That is, cleaning after every patient. In case of a suspected patient, what are you going to do with that space? Will you close it down for 2 or 3 hours or the rest of the day? Most obviously outpatient practices don't have negative pressure rooms. So that's something that you need to think about, how you're going to ventilate that area. One idea to try to separate your patients is doing cohorts. So that is, if you have patients coming in for their vaccines and their routine care, ask screening questions, make sure that the child is well and no one is sick, and those kids perhaps can come at a certain block of time. As for sick patients, then those can come at a different time of the day, making sure that you have those strategies in case someone has a COVID-19 infection, that you can provide safe care for that patient and not cause cross-contamination with, to other patients. I'll use an example, what I'm doing in my practice currently. We did do the cohorts. I have one office, so I see my well babies in the morning with one caregiver. Don't allow multiple people to come in with the patient. We screen everyone at the beginning, make sure no one has any respiratory issues or other illnesses. And once we're limiting how many people are present in the office. So this allows for adequate social distancing and minimizing any infection in case we have an asymptomatic patient. One thing we do also require that all adults and children over 2 be wearing a mask when they enter the facility. As far as our sick kids, we set up a tent outside, and myself and the staff, we have full PPE, including N95 masks, because we do swab and test for these patients. And as you know, pediatric patients are coughing and sneezing, and just basically they're an aerosol moving around. So with those patients, we take care of them outside and are able to do all kinds of testing and treatment accordingly. Telemedicine has also been useful, extremely useful and you can utilize this for so many things. As not every encounter with a patient requires a physical exam or a complete physical exam, especially if you have established relationship with patients and you've known them and you know their history. So ideal visits for telemedicine could be any mental health issues, psychiatric issues, depression, anxiety, ADHD. And if you're in pediatrics, you'll be aware that the rates of anxiety have skyrocketed since this whole pandemic has started, and a lot of children are suffering from anxiety. So this would be ideal to use that. You can teach the parent to take some, check a pulse, measure that respiratory rate. You can ask them to get a weight if acceptable, or measure height, and you can have like a limited set of vitals. With your visual physical exam, you can tell whether a patient's in distress or not. You can ask them to breathe for you, see if they're coughing, are they having retractions, nasal flaring, things to that effect. That would determine the acuity of the illness that the child has. Dermatology issues as well. This would be a great platform to treat with telemedicine. So I'll talk a little bit about the presentation of COVID-19 in pediatric patients. Of the total cases of COVID-19 worldwide, reports vary from 0.8 to 2% of the total cases. The incubation period in children has been noted to be anywhere between 2 to 14 days. Symptoms include fever. Fever is 100.4 degrees Fahrenheit, or is it 38 degrees Celsius. Upper respiratory tract symptoms, runny nose, cough, sore throat, conjunctivitis have been noted to be a presentation in children with COVID. Shortness of breath, difficulty breathing, chest tightness. GI symptoms have been reported as well, mainly diarrhea, and it could be the only presenting symptom. Fatigue, body aches, myalgias, and poor feeding in children under age 1. However, keep in mind that they could also have no symptoms at all. When you're thinking about the clinical considerations, over 50% of children will present with a mild illness. So, have a high index of suspicion for these patients. Only less than 1% of children developed ARDS and respiratory failure. Those who did usually had an underlying chronic illness, which caused an increase in the severity of their disease. 16% of children were asymptomatic. This is based on data out of Wuhan. I will have the references at the last slide, so you guys can check that out. Other than an underlying chronic illness, the age of the patient also is a risk factor, namely infants who are less than 12 months of age are at high risk for severe disease. Clinical findings in COVID-19 pediatric patients, there is no consistent data on lab findings, unlike in the adult population. Some studies reported neutropenia in about 25% of the samples that were done, lymphopenia in only 3.5%. Procalcitonin was elevated in about 64% of patients, and the CRP was elevated in about 20%. As far as imaging was concerned, different modalities of imaging were very similar to adult findings. Chest x-rays would show patchy infiltrate that are consistent with a viral pneumonia. Chest CT showed nodular ground glass appearance. Ultrasounds would show subpleural consolidation and confluent B lines. However, normal findings were present as well. And keep in mind that these findings are not specific to COVID, and imaging should not be the only tool utilized to diagnose. It could definitely have a patient be a person under investigation. As far as treatment is concerned with children, there is no prophylaxis that is currently recommended in the medical literature. Home remedies, as far as they're safe and cannot cause any distress or toxicities, are fine. But so far, there's no data showing that anything works well, in particular, to prevent COVID-19 in children. For children who are asymptomatic or have a mild disease, self-isolate. So self-isolation means that and this can be very difficult. I can only imagine, like, if you have to self-isolate a 3 or 4-year-old. So just keep that in mind, and you can come up with a strategy with the family of how that can be done. Self-isolation, according to CDC, for people who are positive, is the 3-10. So 3 days from resolution of symptoms. So once they feel better, there's no fever, without any antipyretics, they continue to self-isolate for 3 days, but for a total of 10 days from the onset of the disease. And the only thing you can really do at this time is make sure that you're providing supportive care. So Panadol or acetaminophen, paracetamol for fevers, fluids, cough medications and whatnot, probiotics in cases of diarrhea. Those are all things that can be provided for supportive care for a mild disease. Patients who go on to develop moderate to severe disease, that is, they're having respiratory distress, their oxygen saturation is less than 93% on room air, those children need to be admitted, and you can go ahead and perform appropriate testing, imaging, supportive care, which may include ventilatory support. One thing to keep in mind is the mental health, the family mental health. As I had mentioned earlier, we're seeing a lot of cases of anxiety, depression, and anxiety manifesting itself as a psychosomatic issue, chest pain, headaches, things to that effect, difficulty sleeping. As a pediatrician, you have an important role. You can be the first point of contact for a lot of families, since you establish that relationship when parents are bringing the child in for their vaccines and routine visits. It's important to try to educate and provide communication and strategies to help families adjust how to cope with the current situation and how to build resilience. So things you could suggest depend, of course, on the age group. I try to encourage my patients to try to see if there's any new talents that they can acquire, whether through art, through music, gardening, reading, catching up on any projects that perhaps they weren't able to do, and try to, reassure everyone that it's okay to take it easy. It's okay not to stress too much about certain things, especially with schools and distance learning. These are not, these are unprecedented times. And we all have that underlying level of stress and anxiety going on with everything. And now we're adding the added stress of children having to do their schoolwork, and you have to get the A's, you know, honor roll and all of that. It's okay to relax a little bit and allow the child to vent and in a safe way, and have an activity that helps them feel better about themselves, and just kind of alleviate that anxiety. So by establishing a communication plan, you will be able to as well identify patients who may need more services. Does somebody need counseling? Are they in full-blown depression or anxiety? Are they suicidal? So you need to be aware of who these patients are so you can help them navigate the system in the current situation and provide services for them. The pandemic effect is not only the direct infection that we are dealing with, but with the social distancing, the lockdown, we're having a lot of other effects. There's a decrease in the reports of abuse. Remember, when patients or children are going to school or they're out in the community, if any child is being abused, other adults can identify that and help report it. We're not seeing as many reports anymore. But what we're seeing is an increase in admissions in cases of severe physical abuse. So those families are all locked down, they're stressed out, and unfortunately somebody has an meltdown, and they take it out on the children, and they can lead to severe consequences. Isolation of vulnerable children, obviously, is result of that. We're also seeing an increase in rates of malnutrition. A lot of children depend on food provided in schools and other public facilities since they have food insecurity at home. So we're seeing a lot of that, and that's where it's important to help identify those kids again and figure out what the resources that are available. So those food insecurities can be addressed, whether providing food at home or through the school system. And remember, well visits can help you identify all that when you're doing your weight checks and your exams and everything. And some of that can be identified via telemedicine as well. So if in the case that you cannot see the child in person, just be vigilant, and especially if you have a suspicion. Abuse, of course, is not just physical. Neglect, that is, could be medical or just general child neglect, not feeding children and whatnot, or sexual abuse. Remember, families that are stressed can act inappropriately, but does not necessarily make them bad people. But stress can really take a toll and make people act certain ways. Remember, your conversation with the family may be the lifeline that they need. And here's a list of resources that I use for this talk. International Pediatric Association, the CDC, Center for Disease Control, American Academy of Pediatrics, UpToDate, which is normally a paid software. They have a whole library full of coronavirus disease data that is available free to everyone. Thank you.
Thank you so much, Dr. Salma. And thank you for all of our doctors. It was really a great presentation, and I learned a lot, and I think all the viewers join me in this. I will just take a couple of questions, 1, 2, 3 questions, and then we will wrap it up. So I'll start with the first question here. Okay, so I have a question for Dr. Mohamed Akoud. Akram is asking, what is the management of acute anxiety during the third trimester of pregnancy? I think he means maybe now they are seeing more anxiety cases. Like if the mother discovers that she's COVID positive or something, so how will you deal with that?
Yeah, as the Salma mentioned, there's an increased rate of anxiety in this critical pandemic time. Uh, for anxiety in pregnancy, the main issue in third trimester is the withdrawal symptom for the neonate. So this patient can be treated with Ativan or Zoloft accordingly to her symptoms. If she had like significant anxiety, she can get treated with Ativan, but it has higher risk of neonatal withdrawal symptoms. Zoloft had less withdrawal symptom in the neonate, and it can be used if there is mild anxiety. But in general, in third trimester, you can treat the patient as if she is not pregnant. There is no concern about side effects, a part of the withdrawal symptoms.
Thank you so much. The next question is for Dr. Mohamed Ibrahim. I think now with the good results that I've been hearing about with the remdesivir, people are excited to start using it for the COVID patients, and they are asking about the safety of remdesivir with pregnancy. Just if you can unmute yourself.
Remdesivir just approved by the FDA, I think as of today or yesterday, for the treatment of COVID-19. And most of the information about the drugs in the treatment of COVID are coming from the recent trials, which released by Gilead recently. This trial involved about 1,063 patients. That's general community, general population. Okay, we don't have how many patients. It's not particularly on pregnant patient. What they came out with the trial is the drug is safe to be used, has low side effect profile, and it's shortening the duration of the illness from 15 days to 11 days, which allow people to expedite the hospital discharge and the treatment and the cure for the disease. The drug is seem to be promising, but I'm not excited so much about it yet until we get more information and regarding the safety and the profile. Regarding the drug safety, as you know, most drugs, the duration of usage can affect the safety of the drug, which is the good thing about this trial, that they found a subdivision of patients in this trial, about 300 plus patients. When they look on those patients, they use the drug for 5 days and another group for 7 days. So they didn't find any difference in the drug safety and efficacy on extending the duration of treatment more than 5 days. So that also can be added to the safety profile of the drug. So using it for shorter duration than more than 7 days or more. So the using less than 5 days. So anyhow, the drug I think is safety-wise is safe to be used during pregnancy, just like other medication like safe in pregnancy.
There's only one thing. So the pregnancy, unfortunately, was one of the exclusion criteria of this trial. So that's why we don't have like much information. But yeah, it seems like a very safe drug, but there's no documentation of that.
Cool. Thank you so much, Dr. Mohamed Ibrahim and Dr. Akoud. I have also a question regarding pregnancy. Wisal is asking about the disease severity in pregnancy and in non-pregnant patients. It seems like she's asking about whether there is a study was made to see how is the severity is different between pregnant and non-pregnant patients. Dr. Mohamed Akoud?
So before we get enough data, we thought COVID-19 is going to be more severe in pregnant women because the pregnancy is immunocompromised or immunosuppressed state. And usually respiratory infection during pregnancy is very bad, and influenza in general in pregnancy is very severe. So that was the expectation initially. But there's a study, I think it's not that big, because the data is still on the process of getting bigger and bigger. So that study showed non-pregnant women does not have severe COVID-19 compared to non-pregnant, but they did not compare the same age patients. Pregnant women in general, they're kind of younger and healthy. They don't have underlying condition. And most of the people who get like very sick, they are kind of old people with underlying conditions. So that study showed pregnant women does not have severe COVID-19 compared to others, but still we are getting more data and data to compare pregnant women to non-pregnant women on the same age and kind of like having non-biased study.
Dr. Salma and Dr. Badreldin, if you have any thing to say about remdesivir and kits, just as we discussed the topic.
So far, the good news for us, personal experience. I'm here in New Jersey. We were hit very hard with this disease. We saw several women pregnant with COVID-19. Fortunately, all babies, we isolate them, we tested them. So far, we did not have any baby with positive disease. So, and I don't think in neonatology, we are going to use that disease, hopefully, use this medication. But the question is for the late onset, as I presented the case for the 3 weeks baby who went home and he came back, and that baby was treated initially with hydroxychloroquine and azithromycin, and we don't know if that helped or no, or several studies now, they did not show that benefit of the hydroxychloroquine here in the United States. But hopefully we don't have a lot of babies suffer from this deadly disease.
So to add to Dr. Badreldin, yeah, since children don't necessarily or rarely get severe disease, there's no data that I saw anywhere addressing pediatric patients with this current medication. This is kind of typical too with new drugs. Usually you see the adult population first, and then we see the pediatric cases later on. So we'll have to wait and see.
Okay, thank you so much. I have the last question for Dr. Mohamed Ibrahim from Salma Elfaki. She is asking, do you use thromboprophylaxis routinely in pregnant women suspect of COVID-19 with upper respiratory tract symptoms? If you can, yeah.
No, not really. The thrombolytics medication, thromboprophylaxis, has to be used for the needed indication, for the designated indication for use. This applied for pregnant and non-pregnant women, but as prophylaxis, there is no specific relationship or indication. COVID-19 is just per se is an indication for using of thromboprophylaxis. It has to be used when it's really indicated. This could be due to the disease complication and morbidity, and also could be to any other indication related to pregnancy or GYN outside of the COVID-19 infection.
Thank you. Thank you very much, Dr. Ibrahim. And with this, we come to the end of our lecture. I want to thank everybody who watched the lecture. I want to thank everyone who shared it with a colleague to make the knowledge spread further. And I hope you find it useful and it added something to your knowledge, and it will help you treat and protect and save lives. I want to thank all of my guests, Dr. Mohamed Ibrahim, Dr. Mohamed Akoud, Dr. Salma Elfaki, and Dr. Badreldin Abdelrahman. And with that, we'll end the lecture, and thank you so much for watching.
Thank you.
Thank you.
Thank you.
Thank you very much.